The warm-up. Now it's time for the keynote speech. It's a great honor for me to introduce our keynote speaker this morning, Dr. Altha Stewart, and it's a special honor for two reasons. Number one, she has spent her career in a place which not that long ago was a very dangerous place to be standing. You know, I was in the state legislature in Connecticut for a long time. The intersection of criminal justice and mental health was a very dangerous place for political people. But Dr. Stewart has led the effort in Shelby County, Tennessee, Memphis, to change the way people think about these things. Second, in her current position, and I want to get the title right, she is the director of the Center of Health in Justice-Involved Youth, and she's also an associate professor at the University of Tennessee Health Science Center. So justice-involved youth is a very special topic for us in Connecticut at the moment. My boss, Governor Malloy, has proposed raising the age of juvenile jurisdiction up to age 21. We'd be the first state in the country to do it. And the rationale behind this is that young people are very different, and there's a special emphasis of criminal justice policy reform at the moment around the country. So, Dr. Stewart, welcome, and please get us going.
Good morning. I don't really think I need to say anything. I think my talk was just given about my own personal professional goal. But I am here in two capacities today. As you heard from Dr. Leifman, I am a member of the leadership of the American Psychiatric Association and serve as secretary of the board of directors, and previously served as the president of the foundation that preceded the one that is co-sponsoring this event today. So I'm happy to add my words of welcome to all of you who journeyed here from far and near to participate in this really historical event where behavioral health professionals and justice professionals and law enforcement and legal professionals are all together sitting to define the scope of the problem and the kinds of strategies to resolve these problems in our jails and prisons today. I do want, though, to, as the people who know me, take a moment to have a point of personal privilege, because I'm also here in the capacity as a member of a team from one of the 50 counties that was selected to participate. And I am over the moon enjoying myself, being here with my colleagues from Shelby County, looking forward to some really great discussion. And I want to take just a second, I know I have a limited amount of time, but I want to take just a second to acknowledge Mayor Mark Luttrell, who is our team leader, a member of NACO, and a true champion for this issue. Mayor Luttrell, please. Give him a hand, please. Up until a couple of months ago, he was actually my boss, so now I can publicly embarrass him, and there's nothing he can do about it. But someone asked me yesterday, what was the most important thing that this group needs to have in place in your home counties to assure that this work gets off to a good start? And without hesitation, I said, the leader who has bought in, who understands, who acknowledges the importance of it, and is willing to support the efforts that need to be undertaken to get you to your end point. And Mayor Luttrell is one of those people. So thank you, Mayor Luttrell. I appreciate the rest of my team, but you really got to give a shout out to the mayor. And you'll meet the rest of them as these couple of days go forward. My job was made easy by the opening panel because you've already heard the accomplishments of Judge Stephen Leifman, who's the Associate Administrative Judge of Miami-Dade County Court Criminal Division. You've heard about his receipt of the Judge Rehnquist Award at the Supreme Court, but what you did not hear are two things that I think are important for you to know before he takes the podium. Judge Leifman was just reappointed for another 3-year term to the American Psychiatric Association Foundation Board of Directors, and we are so pleased that he will remain with us and continue his championing of this work. And for those who don't know, he led the creation of the Judges Leadership Initiative, one of the signature programs of the foundation. And I'm sure many of the judges in the room have participated in that excellent training. And if you haven't, I encourage you to connect with Judge Leifman and do so. Like Saul, I've known Fred Osher for a long time. I know I had black hair when we first met. I'm not sure about Fred. But Fred serves as the Director of Health Systems and Services Policy at the Council of State Governments Justice Center, and where he oversees the health components of Justice Center initiatives. He provides technical assistance across the country to state and local governments, seeking to improve their response to people with mental health and substance abuse disorders who are involved in the criminal justice system. And I can tell you from personal experience that his technical assistance pays off in bringing good people to the table when you need them, because it was Fred who worked with the University of Tennessee to identify me to develop the Center for Health and Justice Involved Youth. So I know his technical assistance works. Having said that, I want to invite them to begin their discussion, and thank you all for, again, for being here.
Well, thank you, Dr. Stewart. I think I appreciate the long view. And it is a journey that we're all on, and really appreciate all of you taking time from your busy days to join us here in conversation over the next day and a half. We've got folks from Maine to Hawaii, from rural Georgia to urban Chicago, all in the pursuit of a common purpose to reduce the prevalence of persons with mental illness in our jails. I'm going to start with, a statement about how we got to this place in time, then share with you some of our experiences in working with counties around the country and the challenges that you face, and then tee up a conversation that will follow about what we believe are the components of a strategic approach to achieve our end result. This is a graph that many of you are familiar with. It's an expanding population of adults under correctional supervision. The top red line is about now 6.85 million Americans under correctional supervision. It actually represents a 1% decrease since 2007 each year, moving in the right direction, as Dr. Leifman suggested, bending the curve. We also have just under 5 million individuals that are in our communities under community correction supervision, probation and parole, giving us an opportunity to integrate some of our best practices in community corrections with those in behavioral health. Our prison population now is about 1.5 million, and our focus of the next day and a half on our jails, where there are 745,000 individuals. So fewer people in our jails on any given day, but it's a churning environment, and it's where the action is. And we this year will have about 11 million individuals arrested and sent to jail. That represents about 9 million as an unduplicated count, of which 2 million of those meet our criteria for a serious mental illness. We are gratified in part that the number has gone down. Again, the red line actually represents percentage change over time, while the bars show a slight decrease. And we really hope that through our efforts that decrease is exaggerated. However, that decrease has not been evenly distributed across jail populations. We were asked to, at the invitation of Commissioner Schreier at that time, to come into Rikers Island, look at their population of individuals with mental illness. She was quite proud of the fact that the average daily population from 2007 to 2012 had dropped from over 13,500 to under 12,000. However, during that same time period, those individuals with mental illness actually went up in both absolute numbers from 3,300 to 4,300 and percentage from 24% to 36%. While we were enjoying a reception last night, 60 Minutes was playing across the nation, and one of their segments was on Rikers Island and the problems that they confront. And it was not a pretty picture. And the city is in the middle of significant reform at this point in time, but that show, shared with millions across the country, highlighted the problems that we're here to discuss. We know that there is way too many people with mental illness in our jail systems. In a study that Dr. Stedman and I conducted with colleagues several years ago in 2 jails in Maryland and 3 in New York, looking at 20,000 admissions over the course of 6 months, we identified 17% of those people on booking meeting our conservative criteria for serious mental illnesses. That is 3 to 6 or 4 to 8, depending on gender, times the population in our general population. Men, 14.9% of men booked. Women, 31% of women booked into those facilities, meeting criteria for serious mental illness. And that's just the booking number. There's a concentration effect that occurs in your jail as folks with mental illness have difficulties getting out. And so the numbers we hear about standing populations are in the range of 22 to 26% if we use the appropriate methodology. And importantly, 3/4 of these individuals meet criteria for a co-occurring substance use disorder, which both may explain their pathway in, but certainly complicates their exit from and reintegration back into our society. That means the modal individual that you have with serious mental illnesses in your jail also has a co-occurring substance use disorder. And as in the general population, this group is characterized by a disproportionate number of men and women of color, with incarceration rates for blacks 6 times higher than that for whites. Another factor that we need to consider in developing appropriate responses. Every day, news stories about people with mental illness are on the front pages. So whether it's from the Columbus Dispatch, which says mentally ill inmates at the Franklin County Jail stay longer, or from the Pima Press, inmates with mental illness inundate the Pima County Jail. Johnson County Sheriff reports mental health is the #1 problem. Over and over and over, this is making headlines in our nation. So let's try to understand what that's about and unpack those numbers, okay? And there are several factors that drive this particular crisis. I'll start with the fact that you have to be arrested more frequently in order for that to occur. And that is in part related to substance use disorders. If you have a mental illness, you're 3 times as likely to have a substance use disorder. And if we're picking up people for possession, sales, and trafficking, we're differentially bringing in individuals that have serious mental illnesses. It is also the case that we have an affordable housing crisis in this country. It's kind of hard to call it a crisis. It's like a feature of our landscape. It has been there for decades, but still, people do not have adequate access to housing that they need. A homeless individual is a very visible person within our community, often getting the attention of law enforcement, frequently for misdemeanor offenses, which pile up and end up with deeper penetration into our criminal justice settings. The other factors that contribute to this overrepresentation: longer periods in jails and prisons, controlled for charges and sentencing. In our look at Rikers Island, in pretrial status, defendants with mental illnesses were there 79 days, average length of stay. Those without, 40 days, twice as long with a mental illness. And we know from recent research that even short periods of time in pretrial settings really messes up your life. A day or 2 or 3, you've lost your job, you can't pay your rent, your family's disrupted, you're more likely to take a plea, you're more likely to be convicted, you're more likely to have longer sentences, and so this pretrial period is one that we want to be thoughtful about as we design our strategies. It is the case that many people in this country have limited access to health care, many uninsured still at this point in time. The Affordable Care Act, which many of your states have enacted and expanded to allow those individuals with low income to have Medicaid, has been a part of the solution. Many of you are in states where Medicaid expansion has not occurred. So without access to health care, it's tough to stabilize a serious mental illness and move on with your recovery. We also know that once out, people with mental illness come back more often. Not always for new charges, new arrests, but frequently for violating the technical conditions of their release, brought back into jail for not paying fines, for not keeping appointments, for turning in urines that may be positive for drugs. It is also the case that despite the wonderful science that allows us to say with confidence that mental illness treatment works, many people don't have access to the evidence-based practices that are associated with those good outcomes. And we'll ask you and your community to consider what's out there, at what capacity, with what existing gap, so we can ensure that folks get the best that science has to offer. And the last factor that I'll just spend a little bit more time on is people with mental illness end up in jail for many of the same reasons that people without mental illness do. And so we then need to understand what these criminogenic risk factors are. It's not a term that I made up or was asked to vote on. It's a term in our literature, with our criminal justice community. And as a behavioral health partner, I need to understand it. When this study came out, Peterson, Scheme, and colleagues, they looked at 143 defendants in Minnesota jail, charged with 439 different crimes, spent 2 hours talking with them and said, how did you end up here? You have mental illness. Was that the cause? Through this interview process, 2/3 acknowledged that it was completely independent of their mental illness that they ended up in that jail setting. And less than 1 in 5 could say that it was directly related to their mental illness. What do I mean by directly related? I have schizophrenia, I have delusions, I'm fearful people are going to harm me, I see someone that might do that, I hit them, I'm arrested and brought to jail, okay? What do I mean by independent? I have schizophrenia, I haven't been able to work, I'm hungry, I steal some food, okay? And so for the majority of individuals with mental illness, they got there for factors that are similar to people without. And we call these criminogenic risk factors. We can measure criminogenic risk in 2 ways, with static factors that are unchangeable, okay, and with dynamic factors. But I want to be clear what I mean by risk. And I'm not talking about the crime type or dangerousness or violence or failure to appear. All those are important dimensions to consider in sentence and disposition. But I'm talking about how likely is a person to commit a crime or violate their conditions of supervision. On the left, some of the static factors that go into measurement of risk. On the right, and importantly, the dynamic factors. Why important? You can't do anything about your history, but you can do something about your current behavior. And these are the dynamic risk factors that one needs to attend to. These all, as risk factors, allow us to use information to make treatment, supervision, release decisions in a more informed and valid way. It is embodied in the risk-need responsivity paradigm, increasingly guiding some of our correctional choices at this point in time. The risk principle says, focus on people that are higher risk to produce victims in the future, to commit new crimes. Those are the people with whom, if we provide adequate supervision and treatment, we can reduce the likelihood of their return to jail and prison. The needs principle says, focus on those things that are associated with their involvement in crime, their criminogenic needs related to those risks I described earlier. Those are the things that people need help with if they can desist from crime and move forward in their recovery. And then the last R is the responsivity principle, another made-up word. However, you didn't see mental illness in that list of central 8 risk factors. It isn't an explanatory factor for involvement in the criminal justice system. However, mental illness is a responsivity factor. Responsivity refers to accommodating our interventions to the culture, race, ethnicity, gender of those individuals, but also to the mental health of that particular individual. Mental illness affects all of these factors. If I'm unable to sleep, losing weight, very despondent, thinking of killing myself, all criteria for a major depressive disorder, how likely is it that I'm going to be a good group participant as I think about criminogenic risks and needs? I won't even go to the group. If I go to the group, I'm not going to be able to concentrate. So treatment for my depression, absolutely necessary, but not necessarily sufficient. That and those strategies that allow us to make better choices going forward. This information allowed us to develop a framework for strategic planning to think about the target population that enter into your jail doors. They all have a risk profile, and we need to screen and assess for that and understand where they sit from low to high. We have huge rates of substance use disorders in our jails and prisons, 60 to 80%, depending on how you measure it. We need to understand its presence and its impact on that individual. Next, for our discussion today, we need to screen and assess for mental illness. And in risk, substance use, and mental illness, you can then characterize individuals coming through the jail and put them in separate categories, each of which require a differential response. But it's helpful for planning purposes. I highlight 3 boxes. On the left, individuals with lower risk, but significant behavioral health needs. We're not saying do nothing. Your screening, assessment, and diagnosis within a jail may be the first time an individual ever recognizes that they have a serious mental health condition or a behavioral health disorder. Get them connected to treatment. That's our responsibility. On the right side, those three boxes, moderate and higher risk individuals with behavioral health needs. This is where we collaborate, where we bring the best of our corrections practice to the best of our behavioral health treatment in a coordinated and collaborative response to help that individual move forward. We've worked in several counties over the last 6, 7 years, and we've learned a lot from all of you about the challenges you face, which are enormous. I'll highlight 4 of them: being data-driven, using best practices, continuity of care, and measuring results. Being data-driven, all right? People face complex matters, you know. This is the results of a sequential intercept mapping, a very important step for counties to understand the availability of services and programs within a community. But this is just the step. Without putting numbers to this, we can end up believing that that mental health court, very important with a research base, not minimizing its impact, but serving 50 participants when there are 2,000 defendants with mental health needs, it's a small piece of the puzzle. But we have to have numbers in order to understand that. We also need to know who the target population is, so that we go around counties and before we get there say, you doing mental health screening and assessment, substance use screening and assessment, risk, oh yeah, doing all that. But we land on your doorsteps and we uncover what we see is a system that doesn't do it in a valid and reliable way, or doesn't do it universally, or doesn't do it in a comprehensive fashion that you can characterize your target population. And if you can't do that, then you have a difficult time addressing their dynamic needs. In particular, those needs in the top, when I was being trained, I was told that people with antisocial personality patterns had a chronic or enduring illness that could not be affected or changed. It allowed us to list them on Axis 2 in our diagnostic schemata and discard them. Can't help you. It's not true. People do change and can change and will change if we provide the appropriate interventions. Thank you. Oh, so nice speaking to the choir. We also understand, you know, the need for substance abuse to be addressed in an integrated way. That's the evidence-based practice. But we have this science to service gap. And in this survey, this pie chart sort of reflects people that were identified by a SAMHSA survey that's conducted every couple of years as having co-occurring disorders. Ask the question, what kind of care did you get? 40% of them had no treatment in the past year at all, didn't have insurance, didn't want to go, couldn't find anybody. 45% mental health treatment only, about 6% substance use treatment only. That's not the evidence-based practice. It's providing integrated treatment to both conditions at the same time. That's integrated care. About 11% of people got that. So we're not using our science in the way that we are taught. We also, and challenged by using best practices, don't always apply what we learn in terms of our risk principles. So if we take individuals without any accommodation to what their risk level are and put them in a variety of programs, we are putting high-risk people in low-risk settings and low-risk people in high-risk settings. That's not likely to work. If we assess for those factors, we can characterize individuals, but unless we apply the results of that characterization and sort people out into different groups, we're not going to be able to get the recidivism reduction that we expect from good interventions. And further, we may end up putting low-risk people in high-risk supervision settings, making their likelihood of return to criminal justice higher than if we did nothing at all, violating a basic principle of my medical practice, do no harm. We actually can do harm if we're not thoughtful about how we respond to people and understand their risk. We also won't get any impact by putting high-risk individuals in low-risk settings without adequate supervision and treatment. So that's the challenge. Challenge 3, continuity of care. Franklin County, who's here in the house, were gracious enough to allow us in. We looked at annual bookings to their jail in a year, a little over 10,500. They didn't have at that time a screening and assessment process to identify mental illness. So we borrowed the data from the ADAM board, their mental health board, which had the roster of individuals they characterized as serious mental illness, cross-matched it with the booking population, and came up with 970 people that were admitted that were diagnosed with serious mental illness. We then followed them 12 months after their release. A third or more never got any contact with behavioral health after leaving, even though they were known to the system prior to their entering the jail. We used national data to extrapolate to the fact that we believed at that point in time in Franklin County that over 100 individuals a month with high risk for committing new crimes and high behavioral health needs were being released onto the streets with no access to care. We need to understand this continuity issue. We also are challenged by tracking progress. Up on the top is a sequential intercept map, moving from law enforcement through release back into community. And at each of these places, there are opportunities to do things different. There are 4 key metrics that we're asking you to consider, and you'll hear these throughout the day and a half. Reduce the number of people that are booked into jail. If they don't need to go there, don't take them there. If they get there, shorten the length of stay for them so that they can move out quickly into the community. And we also want to increase the likelihood that they land on their feet and are connected with care. And once in our community, provide support, supervision, and treatment so they aren't likely to come back. These are the things that we want to measure. So, how do we move forward? And I'm going to violate the time code here. Probably need 5 more minutes. Great. We move forward with all of you. Had a call to action. 250 counties passed resolutions. You all were invited to attend this summit as 50 representatives of those counties, doing the hard work, doing the good work. We have an overarching goal. We share this goal that there will be fewer people with mental illnesses in our jails tomorrow than there are today. And we believe that there are components that will make your strategic plans more effective if you can follow and adhere to them, and we will be discussing these throughout the course of the next day and a half. We want to have committed leadership. And hey, you're here. You know, you are the leaders. I heard someone checking in at the line and said, hey, we brought our A-team. You did bring your A-teams, and we appreciate that. You have passed resolutions, and you're here, again, trying to do better, trying to improve. We did a poll of all of you, and there was 1 respondent per county, so this reflects 50. We're going to have polling questions a little bit later. And we asked you, how many of you are screening for mental illness, screening for substance use disorder, screening for risk? And here are the results. 3/4 of you said you are, okay? Mental illness, about half substance use, less than about a 1/5 criminogenic risk. But are you really? When we go around the country, we hear, oh, I've got 20% of my population with mental illness. I've got 60% of my population. I've got 80. How can that be? All right? And what we really want to make sure is that we're actually have a definition of mental illness that is consistent from jail to community. We were in Salt Lake County. The jail had a definition of serious mental illness. Didn't look anything like the community definition of serious mental illness. And then there was this mismatch, particularly when people were sent out. They weren't getting access to the treatment and services that they needed. We asked you about baseline data. Do you collect these metrics? 64% of you said, yeah, we can sort of tell you who's in our jail with mental illness. Fewer, no average length of stay. Fewer yet, the connection to treatment or recidivism rates, okay? And so we think that this is an important thing. How else are we going to understand if our prevalence rate goes up or down if we don't have a baseline to start with? So we need to establish that at the outset. And we need to put it somewhere, not on a paper in a pile, that can actually be queried in a way that can inform our progress going forward. Have you conducted a comprehensive process analysis and inventory of services? This process analysis is critical from dispatch to adjudication, through release. At every point along the way, there are challenges, and you all know them well. Is the information collected? If yes, is it recorded? If it's there, who gets it? And when? All right? So that we protect privacy and yet at the same time allow our system to do a better job of understanding who we work with and what their needs are. Have you prioritized your policy, practice, and funding? At every point along the sequential intercept map, there are opportunities to do things differently. And have you, in your work, made decisions that are strategic, that have a high impact with the opportunities that exist? Are those strategies consistent with the measures and metrics associated with reduction in prevalence rate? Do you have money that can pay for it? I know a big elephant in the room here, But we need to look at what our counties have and can provide, our states, our federal government, private foundations, private industry, all can contribute necessary resources to close the gap between what exists and what people need. We asked you, how many of you can track these metrics over time? This is a challenge, and we understand that. 11% of you thought that that was possible with the data that you had in hand. So we're looking for routine tracking of the metrics, reporting out. We're asking our county officials to ask for the results on these metrics over time so they can assess the likelihood of success of your program. So it's that we challenge you with. This is hard work. There's no doubt about it. We understand. If it was simple to reduce prevalence rates, we wouldn't have an initiative. You'd have done it already, okay? So we're in this together, learning from each other, trying to network. Those are the components. I want to leave you and move a little bit from the abstraction of data and policy into a more personal realm, sharing with you 3 stories. We at the Group for Advancement of Psychiatry released last week a book on mental illness in the criminal justice system that's targeted to behavioral health community, suggesting ways that they can be a part of the solution. The important part of this book is that it was derived from a letter that Dear Abby placed a couple years ago, asking her readers, can you share your family members' experience that have mental illness with criminal justice system? We got about 2,500 letters in less than 2 months, every one of which would tug at your heartstrings. The mom, the dad, sister, brother, who called for help thinking they were going to get treatment and ended up with their loved one penetrating deeply into the criminal justice settings. We felt a responsibility to them, use their letters for this book. Second story that I'll share with you is a bit more personal. In 1961, my father received a call from the Clark County Sheriff's Department letting him know that his wife, my mom, had been arrested for disturbing the peace in a local casino in Nevada. There was relief. She was found. She was missing for several days. There was shock. How did this middle-aged woman in the middle of a hypomanic episode make it all the way out to Las Vegas and get arrested? And then there was the process of restoring some semblance of normalcy to our lives. Brought her back, got her admitted to a psychiatric facility. She participated in the early research on lithium and bipolar disorder, a medication that made all the difference in her life going forward. But it is a story that we don't talk about very often. We're ashamed at that point in time of it. It had a major impact in our lives. My mom isn't a criminal, wasn't, isn't, and won't be, although she's passed away. And that it was important for us to sort of figure out the right strategies. And we were fortunate. We had some resources and could bring her back. These are the things that sort of keep us going here. Each of you have stories like that of family members and loved ones that have had an experience which we know if we could do a better job of getting people connected to treatment, that we could mitigate the likelihood that they end up in custody. And I want to thank you for the conversation that we are going to have together over the next day and a half. In service, again, of those personal stories, I want to introduce Judge Leifman through a film that he has produced in Miami-Dade. And this documents some of the significant barriers, challenges, and tragedies that exist. We'll play this for you now. You'll then get to hear from a champion who has worked in a community that has actually achieved many of the outcomes that we'll be talking about here, but would acknowledge that the collaborative effort it took to get there was enormous, and there's a lot of work that still remains to be done. So with that, let us play the film, and we'll move forward with this plenary.
Hi, everybody. Thank you for inviting me to attend.
Prison insiders call this the forgotten floor, but it seems unimaginable that the horrendous, be it horrifying conditions of a jail spilling over with inmates suffering from mental illnesses could be erased from any sane man's mind. As frigid air is pumped into sealed cells, some beg for help for the barest of necessities, water. The faucets are dry. The water's not working.
The water's not working. He's drinking sewer water. He's drinking toilet water out of the toilet.
We'll get you water. It doesn't work, the faucets. The faucets aren't working.
These stench-filled cells were designed for one person, outfitted with only a single steel shelf for a bed.
In this one, there's 3 inmates in a cell for one.
Yet 2, 3, sometimes even 5 men diagnosed with mental illnesses, in most cases arrested for low-level felony crimes, in some cases misdemeanors, are locked up for days, weeks, months. Therein lies the danger. William Weaver Sr. was caring for his 40-year-old son Bill at home, a son he says suffered from schizophrenia but functioned well for decades until his medicine was changed. Then one night, according to police records, he attacked his elderly father, who called police and urged them to arrest his son, hoping this would trigger treatment.
Because he was under the false idea that if he got arrested, he'd get treatment.
Bill ended up locked up in a cell on floor 9 of the Miami-Dade pretrial detention center for several months. According to authorities, Bill jumped from this top bunk bed, cracking his skull and breaking his neck. He's now a quadriplegic who needs hospitalization to stay alive. We met up with his father, who had just left his hospital bed.
Do you think anything has come from what the incident of what your son went through?
Nothing. Nothing's changed. Do I think something could change? I don't know. I don't know. It's time. It's time. Something changed. But I don't know if it ever will.
A pretty sobering look at the state of our mental health system, not just in Miami-Dade, but unfortunately around this country. Tragically, last year, the young man featured in that video passed away as a result of his injuries. And soon thereafter, his father passed away, probably from a broken heart. But things do change. Thank you, my Miami-Dade delegation. We closed that horrible 9th floor. Absolutely. And in the last 16 years, we have made major systematic changes to move us forward and on a path that we can be very, very proud of. When I became a judge, I had absolutely no idea I was actually becoming the gatekeeper to the largest psychiatric warehouse in the state of Florida. Sadly, the Miami-Dade County Jail. In the United States, while we have 5% of the world's population, we have 25% of the world's inmates. 1 out of 104 adults in the United States right now are sitting in jail. 1 out of 33 adults in the United States are under court supervision. Since 1980, the number of people going to jail has tripled, and the time of sentences has increased by 166%. If you drill down and you peel away that onion, what you are going to find is most of this increase is directly due to untreated mental illnesses and substance use disorders. People in the United States are 9 times more likely with a mental illness to be incarcerated than hospitalized. They are 18 times more likely to find a bed in the criminal justice system than in any state hospital. This is a shameful American tragedy, and it is one that must end. The counties are spending almost $70 billion a year to incarcerate people. My journey into the mental health world actually began one morning when I was getting ready to go on the bench. I was approached by the assistant public defender and the assistant state attorney, and they asked me if I would speak to a couple whose son was in jail on a case I was about to hear. At the time, I was handling low-level misdemeanor type offenses, and there were I was handling the division for people that were still in jail on these low-level offenses. Basically 3 kinds of people in this division. Those with attached felonies who were not allowed out, those that were too poor to bond out, and then those with mental illnesses that just didn't know how to get out. This lovely couple, very sophisticated, came into my chambers. They were horribly shaken. The mom was crying, the dad was literally shaking, and they started to beg me to get their son help. They told me that their son was brilliant. He had gone to Harvard. He had a late onset of schizophrenia, and he was now homeless and recycling through the criminal justice system. I was pretty new at the time, and I think when you're a new judge, you think you have a lot more power and a lot more wisdom than you really do. My colleagues are laughing along with me. And I made the mistake of promising them that I would get their son help. Because you see, I was under this illusion that, since I deal with logic, that if you got arrested and you had a mental illness, of course there must be some kind of treatment system, because I knew that if you got arrested and had a heart attack, there clearly was a system of care for you. So I just assumed the same must exist for people with mental illnesses, because at that point in my state and around this country, judges had absolutely no training on what to do or even how to identify people with mental illnesses. So I went ahead and I made this promise that I will regret for the rest of my life. I promised them that I would get their son help. As I started to get ready to go back into the courtroom, the mom stopped me and she said, "Judge, there's one more thing I need to tell you about my son." She said, "Not only is he brilliant, but he probably knows more about the mental health system than you do." I looked at her a little odd. I didn't know what she was saying, and she said, "You see, my son is a psychiatrist at Jackson Memorial Hospital, the largest the largest public hospital in the state of Florida." I was pretty taken back. I went into the courtroom and I called his case, and he stood, and we started to have an amazing conversation. He was thoughtful. He was coherent. Quite honestly, he was more respectful than the lawyers. And I was sitting there thinking, my God, maybe there's something wrong with his parents. This doesn't really add up. Except when I looked at him, he looked like a homeless man who hadn't bathed in 3 months. And he kept insisting there was absolutely nothing wrong with him, and that if I would just release him, he promised he would come back and he would go see a psychiatrist. And I have to tell you, I think he was in on some serious offense like possession of a dairy cart, one of those little ordinances that often are used to pick up people to get them off the street, mostly homeless. And he was probably already in, I don't know, 4 to 8 weeks longer than anyone else ever would have been without mental illness on that charge. And I said to him, "Can I ask you a question?" He said, "Yes, Your Honor, anything." I said, "I just don't understand one thing. You keep insisting that there is absolutely nothing wrong with you. But why would a Harvard-educated doctor be homeless, in jail, and recycling if you didn't have a mental illness?" And all of a sudden, he got a look on his face that I will never, ever forget. It is a look that I can only describe to you, that someone must look like right before they think they're going to die. It was almost a look of a wounded animal, and all of a sudden he started shaking back and forth. He started cupping his ears, and he had a full-blown psychotic episode right in front of my eyes. And he started screaming at the top of his lungs, and he started pointing to the back of the courtroom, and everything he said he repeated in sixes, and he started yelling, "Your Honor, Your Honor, Your Honor, Your Honor! You have to have the couple removed, couple removed, couple removed." I said to him, "Aren't those your parents?" "No, no, 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 no. My real parents, real parents, real parents, real parents. Died, Holocaust, 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 Holocaust. And they are from the CIA, 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 and they came to kill me, kill me, kill me, kill me, kill me." And the only thing you could hear was his mother crying. I did the only thing I had been taught. If someone acts strange, order a psychological evaluation. That was the extent of my training. I immediately ordered the evaluation. A couple weeks went by. He's now in jail, I don't know, 8 weeks on possession of a dairy cart. The evaluation said not only was he incompetent to stand trial, but he needed immediate hospitalization because he met criteria for hospitalization. At the time in Florida, I needed 3 evaluations, so I had to order 2 more. Another 4 weeks went by. All 3 evaluations came back. He was incompetent to stand trial, and he met criteria for immediate hospitalization. I'm thinking, this is great. I'm going to be a hero. I'm going to fulfill the promise. I'm going to get this guy help. We're going to all live happily ever after. I hand the evaluations to the lawyers. The public defender starts to grin. I will tell you, I am a former assistant public defender. The grin is a really bad thing. And then she utters this comment that my colleague over there will appreciate more than anything. She said, "Your Honor, in all due respect." Now, when the lawyers say that to the judges, it has nothing to do with respect. Trust me. And I said, "Excuse me," and she whipped out a Florida Supreme Court opinion, and it said county court judges, of which I am, had absolutely 0 authority to involuntarily hospitalize anybody, and my only option was to release him back to the street on a conditional release and tell him to go see a doctor. That was 16 years ago. He never came back, and I cannot tell you today if he's dead or alive. 3 days ago, the governor signed a law, because it took us 16 years to fix it, that finally gave county court judges the authority to hold on to people who were incompetent. So things can change. I learned 3 very, very valuable lessons that morning. Number 1, I learned is my own community had a very serious mental health crisis. In fact, we have the highest prevalence of mental illness of any urban area in the United States. 9.1% of my general population, that's over 170,000 adults and 52,000 children who live in my community, live and suffer with serious mental illnesses every day. 35% of the inmates at the time were on antipsychotic medication, and we were spending $218,000 a day, that's $80 million a year, to warehouse people in the conditions you saw on that video that you wouldn't let your dog stay in. And that because we had done a horrible job training our law enforcement how to deal with this problem, we have had more than 25 people die during an encounter with law enforcement because the police had not been trained, people with mental illnesses. At one point, there was 1 shooting a month of people with mental illnesses. The second lesson I learned is this was not just a local problem, but as it turns out, it is a state, and as all of you know, a national one as well. Former Surgeon General David Satcher calls mental illness the silent epidemic of our times, but if you work in the criminal justice system, there's absolutely nothing silent about this epidemic. And the third lesson, and maybe the most difficult lesson to learn, is that our community mental health systems are horribly fragmented, they are difficult to access, they are horribly under-resourced, and they do not necessarily reflect best practices, modern medicine and modern science, and all of the laws dealing with mental illness and the financing of mental illnesses are more than 40 years old, and they need to be reformed. The good news is that this is fixable. None of us are Superman or Superwoman, but I can tell you from my experience that 80% of the solution lies in the community, which means it lies with you. It's about putting aside our silos, it's about putting aside our differences and figuring out a better path on how to deal with this problem. We started with a small summit where one of the good things about being judge is you can bring people to meetings that don't necessarily want to go. And we actually mapped out clearly how our community mental health system intersected with our criminal justice system, and what we found is that we were embarrassingly dysfunctional. We were part of the problem. And then when they didn't behave the way we expected, after we didn't give them the services they needed, we would punish them again and throw them back in jail. It's shameful. And so we decided what we needed to do was 2 major things. We needed pre-arrest and post-arrest. And we needed to have a system of care in the community. This is not a criminal justice problem. This is a community problem that requires a community solution. Since that day, we have trained over 4,700 police officers in CIT. We have trained all of our 911 call takers. We have trained all the police chiefs at all 36 police departments in Miami-Dade County. From 2010 to 2015, our CIT officers, just the two major agencies, I have 36. They handled 48,669 mental health calls over a 5-year period and only made 109 arrests. Our jail audit dropped from well over 7,000 to, Assistant Director, about 3,800 today? Oh, it went up. All right. Still pretty damn good. So good, we closed one of our jails, actually saving our county almost $12 million a year in actual savings. We set up 3 post-arrest diversion programs. Now, any misdemeanor that would have affected this doctor 16 years ago, within 3 days is diverted out of jail to a crisis stabilization unit for a couple weeks. They're then afforded the opportunity to get into services and to go into our program. The recidivism rate for our misdemeanor program dropped from 72% to 20%. We do about 500 of those diversions a year. We then, thanks to the state attorney's office, expanded it to our felony cases, nonviolent, including battery on a police officer and resisting with violence. The recidivism rate for that program after 5 years is holding at about 6% for those that finish the program, which is over 70% of the participants. We have saved the county between 35 and 40 years of jail bed days. We know this works. And we are on the precipice of doing even more. We're going to be opening the first of its kind forensic diversion facility, a one-stop shop to have all the services under one roof. We're using advanced technology to start to track and measure this population so we have a real grip and make Dr. Osher very happy. But the reality is not one person, not one institution, not one of us in this room, not one party created this problem, and not one party and one person, one institution is going to fix it. It is going to take everybody in this room to get together, to come up with written collaborative agreements, start slow, figure out how to do it, and move forward. And I am convinced that once we all begin to do this, we will finally accomplish what the United States Supreme Court set out to do when they asked us to deinstitutionalize our hospitals. Thank you very, very much. Thank you. Judges aren't supposed to get standing ovations, trust me. Thank you. Thank you. I was supposed to tell you get a 15-minute break, but because we're running a little over time, you get about a 5-minute break, so please come back as quickly as possible. Thank you.